All right. Good afternoon, everyone. Is my voice clear? Can you hear me properly? Hello? Okay. So our topic for today would be renal. So our genitourinary system will be dividing this one into the normal functions of our GUT as well as our disorders. Plus, we will be adding burns. I'm not sure if you have discussed this one and your other topics, but we'll just include this one as a recap or review for today. And if we have time, we'll also be reviewing our homeostasis or the summary of our ABG. I think ABG is from your respi, but it's also related to your kidneys or metabolic problems. So I'll just be adding some information. All right. So are we ready? Can we start? Okay. So GUT, when we say GUT, what do we mean by genitourinary system? What does it do with our body? What is GUT? What's the function of our GUT? Or genitourinary system. Okay, very good. It is responsible for elimination of what? Of our waste products. Now, when we say genitourinary system, okay, so it's a component of organs that are needed for filtration and for elimination. So we will be discussing here, of course, different parts of our urinary system, which will be focusing on excretion of our waste products as well as regulation of our electrolytes and fluid balance. Let's start off first with our kidney. How many kidneys do we have? This is our bean-shaped organs. Okay, kidney is our blood filtration, okay, that is responsible for removing, of course, waste products. Can I ask you, what are examples of our waste products that are eliminated by our kidney? Can you give me examples of waste products? Very good. Okay, our urea, all right, as well as our BUN and our creatinine. And of course, excess salt, excess electrolytes, all right, will be removed by our kidneys. As well as fluids, do not forget. Excess salt and excess water. Producing, of course, what's our final product? What does it produce? Our urine. Very good. So urine formation, of course, and of course also take note, kidney, all right, aside from excretion of waste products, it's also responsible for regulating our blood pressure, all right, our blood pressure as well as production of our erythropoietin. Erythropoietin, we have discussed this in HEMA. This is a hormone that stimulates what production? What blood cell production? Our EPO. Very good. Our red blood cells. Very good. So do not forget that our kidneys have many functions. What about the ureter? What is the function of our ureters? Very good. So it's a pathway. So these are two narrow tubes that transport our urine from the kidneys to our, of course, bladder through peristaltic contractions. What about our bladder? What's the function of our bladder? Okay, so it's our storage. So this is our muscular sac, okay, that stores our urine until it is expelled from our body. So it may expand or it may contract to accommodate varying volumes of urine. Can I ask you, what is the normal urine per hour level? Good job. It's 30 ml or 30 cc per hour. Okay. Now, would you be concerned if our urine is less than 30 per hour or even more than, let's say, 100 per hour? And that's not good, right? So Keep in mind, okay, that the volume of our urine is very important in order to determine, okay, one of additional presenting signs in order to determine if we have problems with our kidneys. What about our urethra, the last part? Our duct. Urethra is just what? A duct that carries, all right, of course, urine from our bladder outside the body. Now, if we have, say, for example, UTI, who will be more common, females or males, based from the anatomical location of our urethra? Of course, females, because we have smaller and it's more of exposed to external or the environment. Now, the color of our kidney is brownish red, and the location of that one would be retroperitoneal. When we say retroperitoneal, it is same as costovertebral or flank. It's behind, all right? Retroperitoneal, it's behind, or it's in our back. So this is just a quick review of our anatomy for GUT. What I want you to remember, okay, very important, is the functions. Okay, so just remember this mnemonic bean. Okay, we have different functions of our kidneys. Letter B, what can you give me example? One function of our kidneys that starts with the letter B, it is responsible for what? It is responsible for, our kidneys is responsible for regulating our blood pressure. All right. So our kidneys can increase blood pressure, of course, by releasing an enzyme, okay, which we'll be discussing later. It starts with the letter R. What's that enzyme? Enzyme, okay, that starts with the letter R, which can lead to the production of our angiotensin 2 activation. Okay, that would be our renin. Do not forget that one. Okay, our renin will be needed, okay, in order to activate our angiotensins, okay, for vasoconstriction. So we'll be discussing our RAAS later on. Conversely, of course, they can also decrease blood pressure by excreting excess salt and water up to normal BP level. Another letter B, can you give me another function of your kidneys? Another letter B. It is responsible for what? It is responsible for bone formation. All right. Take note that our kidneys, okay, activate what we call our vitamin D. Okay, it converts the inactive vitamin D into its active form, which is of course essential for what absorption? What does our vitamin D absorbs? Vitamin D is needed for what absorption? In order for our bones to become strong and formed. Our calcium. Very good. So again, kidneys convert, okay, inactive vitamin D into its active form, which is essential for calcium absorption, okay, from our bone health or the overall calcium balance in our body. So if we have a problem with the kidney, or if one of our kidneys failed, can we have a problem with the BP, and can we also have a problem with our bone strength? Yes, of course. Okay, what about letter E? What does our kidneys again produce? What hormone? Okay, our erythropoiesis, all right, or erythropoietin production, which is needed for our erythropoiesis regulation. Okay, so our kidneys produce and release erythropoietin, or our EPO, a very important hormone that stimulates what organ? to produce RBC? What does our EPO or erythropoietin stimulates? Very good. Our bone marrow to produce red blood cells, or what we call our erythrocytes. So this function helps maintains our body's oxygen carrying capacity. So problems with the kidney, would there be problem with EPO production? If there's no production of EPO, what can happen to the patient? Anemia, very good. Another letter E, of course, take note that it is also responsible for electrolyte balance. So include in there fluids as well. So its partner, fluid and electrolyte balance. The kidneys regulate, of course, our body's fluid balance by adjusting itself, all right, the amount of water excreted in urine, all right, based on our hydration levels. If we are dehydrated, can we do we pee a lot or do we pee less? Of course, all right? So the kidney will play a major role or a big part on that one. Now, it also, of course, maintains balance on our electrolytes as well. Can you give me examples of electrolytes in the blood, all right? Which is crucial for our nerves, muscle functions. Magnesium, sodium, potassium, calcium, all right? As well as our phosphate. Acid-base balance, are you done with your respi? You will be discussing here our respiratory acidosis, alkalosis, as well as our metabolic acidosis and alkalosis. So our kidneys will excrete, okay, hydrogen ions in response to decreasing our blood pH levels. Now, the kidneys will reabsorb our hydrogen in order to regulate, okay, increase in the blood pH. So it will depend if our body is acidotic or alkalotic. Letter N. What about letter N? What's letter N? Excretion of what? Excretion of nitrogenous waste. Okay, excretion of nitrogenous waste. Our kidneys, okay, primary function also is to remove waste products and metabolic byproducts such as our urea, our creatinine, and uric acid from the body. So these waste products are eliminated from the body through our urine. Take note, these are our waste products. Okay, so just remember the function of our kidneys, our bean. Okay, so without looking in your handouts, can you help me identify functions of our kidney? Letter B. BP regulation. Another letter B. Formation of our bones by activating what vitamin? Vitamin D for what absorption? For calcium absorption. Another function, letter E. What does it produce? What hormone does it produce? EPO or erythropoietin needed by what organ? Organ. For it to be stimulated. Needed by the bone marrow to produce what? RBC. If we have kidney failure, what can happen to the patient? Anemia. Very good. Another letter E. Another letter E. Balance of fluids and electrolytes. All right. Letter A. Acid-base balance. If the pH level is less than 7.35, our body is what? Acidic. What about if it's more than 7.45? Alkalotic or alkalosis. What about letter N? What does it eliminate or excrete? Nitrogenous waste excretion. What are the nitrogenous waste or metabolic byproducts? Can you give me examples? Urea, creatinine, uric acid. Do we need these things or do we need to excrete this one? All right, of course. Through the process of what? How do we excrete this one? What does our kidneys do? All right, through urination. All right, but the kidney itself is a whole organ that, what does it do with our blood? What does our kidney do with our blood? It filtrates. Okay, it's our blood filtration. Okay, removing our waste, toxins, excess water, and electrolytes. All right. So can you tell me what is the specific part of our kidney, okay, that contains tiny structures for filtration? It starts with a letter N. What part of our kidney is that one? Very good. That would be our nephrons. Good job. All right. That's our nephrons. So is this clear? Do you have any questions with the functions of our kidneys? Is this clear? Just remember the mnemonic bean. Do you have questions? Sige, what's your question with the bone formation? Bone formation, ma'am, is also one of the function of your kidney because it activates the inactive vitamin D. All right. Isn't it that we get vitamin D from our diet, such as our breads, cereals, all right, or pastry products, as well as exposure from the sunlight. So that is inactivated. So the kidneys will activate that one in order for us to absorb calcium better for bone strength. So that's the function of our kidneys. It activates, all right, vitamin D. All right. So any more questions? Okay, so let's now discuss. Okay, this is very important, guys. When it comes to GUT, I want you to remember this process. We call this one your RAAS. What does RAAS stands for? What do we mean by RAAS? Renin, angiotensin, aldosterone system. So I want you to remember that in RAAS, we have two goals. Okay, how many goals? Two. Okay, number one goal of our RAAS is to increase blood pressure. Sorry, I'll write it in the chat box. Number one goal is to increase our BP or blood pressure. Number two goal is to increase our blood volume. These are just things that I want you to know when it comes to RAAS or renin angiotensin aldosterone system. Our goal is to increase our BP and as well as increase our blood volume. Now listen first, how does it do? Say for example, there are situations in which our body would drop our blood pressure. For example, a client had accident, all right? And then the client is bleeding, okay? Would that lower our blood pressure if the client is experiencing bleeding? Would that drop our blood pressure? Yes or no? Yes, okay. So, if there are any situations in which our body, okay, would drop our blood pressure, okay, not into normal levels, but low BP level, okay, our sympathetic nervous system will be stimulated. Okay, take note of that. Once our body drops our blood pressure, our SNS will be activated or stimulated. It will now, okay, command the kidney to produce an enzyme called renin. Okay, once the SNS is being stimulated, okay, the kidneys will now produce renin. This is an enzyme, okay, that will stimulate, okay, our angiotensinogen, which is found in what organ? In our liver. Take note of this one first. Once the renin, okay, circulates in our body, of course, it will now activate angiotensinogen, which is found, okay, in our liver. Angiotensinogen, okay, will now be, okay, turned into angiotensin 1. Angiotensinogen will now become angiotensin 1. However, okay, we cannot meet our goals yet to increase blood pressure or to increase our blood volume through angiotensin 1 because this is not a potent vasoconstrictor, all right? It needs to be converted into angiotensin 2, okay, via our ACE that is found in our lungs or the epithelial surface of our lungs. ACE, from the word itself, angiotensin converting enzyme. It is an enzyme that converts angiotensin 1 into angiotensin 2. Now, angiotensin 2 will now have an effect in our body by, okay, being a potent vasoconstrictor. So it will increase our blood pressure and it will also stimulate our aldosterone. Aldosterone is a hormone, okay, found on top of our kidneys, okay, that is needed for reabsorption of water and sodium. Now, if we reabsorb water and sodium, what will happen to our blood volume? Increase or decrease? It will now increase our blood volume, hence increasing our blood pressure. Have our goals met already? Did we meet our goals here? Yes, okay. Is this clear? Do you want me to repeat this one? Can I repeat this, our RAAS? Okay, so answer it with me, okay? So let's review. How many goals do we have in RAAS? 2. What are the 2 goals? Everybody should answer. What are the 2 goals? Increase in blood volume, increase in blood pressure. That is the goal of our RAAS. Okay? Now, in any situations, RAAS will be activated once our blood pressure will go high or will go down. Once our blood pressure drops. Okay, now, when our BP drops, the SNS or our fight or flight sympathetic nervous system will be stimulated when there is decreased blood pressure. Okay, when the SNS is stimulated, okay, it will turn the kidney or it will command the kidney, okay, to produce our enzyme called renin. Now, specific part of our kidney that produces renin, we call that one JGA. I'm not sure if you're familiar with this one, but this is what you call our juxtaglomerular apparatus. Okay, so just remember, JGA is found in what organ? JGA or our juxtaglomerular apparatus is found in what organ? In our kidneys. Okay, so our JGA found in our kidneys will secrete what enzyme? When we have low BP, what will it secrete? Our renin. Okay? It will secrete renin. Now, when the renin is already circulated in the blood, it will now activate a substance in the liver. What do we call it? It will activate a substance in the liver called angiotensinogen. Angiotensinogen. Okay, take note. It will activate a substance in the liver. We call that one angiotensinogen, which will turn into angiotensin 1. Okay, which will turn into angiotensin 1. Angiotensin 1 cannot increase our BP or cannot increase our blood volume right away because it's not a potent vasoconstrictor. It has to be converted first. What do we need as a converter? It has to be converted first, okay? By using our ACE, which is found in what surface of our body? Which is found in our lungs, okay? Angiotensin converting enzyme, it's an enzyme that will convert angiotensin 1 into angiotensin what? Angiotensin 2. Now, would angiotensin 2 have an effect in our body already? Yes or no? One, as a potent vasoconstrictor. When we say potent vasoconstrictor, it will vasoconstrict our blood vessels, leading to what blood pressure, high or low? Leading to high blood pressure, or would increase our blood pressure. Now, would it also stimulate a hormone found in our suprarenal? Yes, what hormone is that one? Our aldosterone. Okay, our aldosterone is needed for reabsorption of what? Aldosterone is needed for what reabsorption? Water and sodium. Take note, sodium and water. Okay? Now, when our body reabsorbs water and sodium, okay, what will happen to the blood volume? It will increase the blood volume. If we have an increase in blood volume, will that increase our blood pressure as well? Automatically will increase our BP. Now, did we meet our goal in RAAS? Yes. Okay. So, thanks to your RAAS. Tell your RAAS. Thank you, RAAS. Okay. Now, this is just a quick summary of our system. Okay, you may take a screenshot of this one or I can send you a picture of this one. All right, so just follow the numbering. Okay, this is just the same of what we've discussed. So number 1, drop in BP. JGA will be stimulated to release renin. Number 2, okay, which will stimulate angiotensinogen that will turn into angiotensin 1. That's number 4. Number 5, our ACE, okay, will convert angiotensin 1 into angiotensin 2, giving now an effect in our body. Now, additional effect of our angiotensin 2, okay, aside from being a potent vasoconstrictor and aside from stimulating aldosterone, it can also stimulate our posterior pituitary gland. Posterior pituitary gland. Now, if you're done with your endo, PPG or posterior pituitary gland is a storage, okay, of what we call our vasopressin. Vasopressin is another term for our anti-diuretic hormone or our ADH. Antidiuretic hormone, okay, it's quite synonymous to your aldosterone, but this time it only reabsorbs water, okay, just water without the sodium. Is this clear, the difference between aldosterone and ADH? Is this clear? ADH or antidiuretic hormone, okay, it only reabsorbs water. Aldosterone, it reabsorbs water and sodium, but it still have the same effect in our body. It will also increase our blood volume. Did you get this part? Yes, ma'am. It will stimulate our PPG to increase or release antidiuretic hormone or ADH. Okay? ADH means antidiuretic. So when we say diuretic, wee-wee ba tayo ng wee-wee? Do we lose urine here when we say diuretic? Yes. So if it's antidiuretic, is it anti-wee-wee or anti-urine? Is it the same effect? Yes, because it just reabsorbs what? What does it reabsorb? Just water. Now, if it reabsorbs just the water, would that also help increase the blood volume? Hence, will that also increase the blood pressure? Yes. Okay, so that's another function, additional function of our angiotensin 2. Potent vasoconstriction or vasoconstrictor, which will lead to increased BP. Aldosterone stimulation, which will reabsorb water and sodium, as well as stimulation, all right, of our PPG or posterior pituitary gland, which is the storage of our ADH or antidiuretic hormone. Another term for that one, we call it vasopressin, which is needed for reabsorption of water. Hence, all of these things, all of these effects of your angiotensin 2 will increase our blood volume and will increase our blood pressure. Figure number 8. Is this part clear, guys? Did you get this part? Yes. Do you have any questions with RAAS? You can take a screenshot so that you would understand or remember this one. Okay. Now, my question, for example, RAAS is working, okay? Would there be a problem or would you be concerned if we have too much of our goals? Too much BP, too much blood volume. Is that also concerning? Yes, okay. Hypertension problems, and that's one of the most common chronic diseases or disorders elderly people have, all right? Or secondary to diseases. Now, if we have, say, for example, increase in BP, too much increase in blood pressure or too much blood volume, okay, we need to stop the RAAS or we need to prevent or block, okay, substances in our RAAS. Now, since you know already the function of our RAAS, okay, we might as well give medications or pharmacological interventions in order to, okay, regulate our BP if it's too high, as well as blood volume if it's too high. Okay? Now, can we block our ACE? Yes, by giving what? Angiotensin converting enzyme inhibitors or ACE inhibitors. These are medications that ends in prils. Can you give me examples? Enalaprils, very good. What else? Lisinopril, captopril, all right? Those are our ACE inhibitors. It will inhibit the work of our ACE or angiotensin converting enzyme. Now, can we also block our angiotensin 2, our vasoconstrictor? Can we block them by giving what medications? By giving our what? Angiotensin receptor receptor blockers. Okay, these are medications that ends in sartan. Can you give me examples? Losartan, what else? Aside from losartan. Tell me sartan, what else? Losartan for the win, sabi ni Ma'am Aki. Now, can we also give vasodilators? Yes. Okay. Can you give me examples? We have our olols, our beta blockers. We also have our calcium channel blockers. Can we manage the blood volume if it's too high? By giving what? By giving, what do we give? Diuretics. Examples of diuretics. Lasix or furosemide. What else? Hydrochlorothiazide. What else? Mannitol. Very good. Now, are all these medications are all these the maintenance medications of our lolos and lolas or our grandparents or parents? Yes. Okay. Now you know already what is it used for. Now if your mommy or daddy ask you, what is this, anak, or what is this? Why does the doctor give me this one? So you might as well tell them the RAAS. Okay, you explain to them the RAAS. Okay, is this part clear? Do you have any questions with this one? Is this clear, everyone? Yes, okay, all right. Now, this is for our BP regulation, okay? Very important, our kidneys, okay, has a major role with regulating our blood pressure. If we have kidney failure, kidney cancer, or even chronic renal failure, all right? Can we have a problem with the regulation of our BP? What can we have? We can have hypertension, okay, secondary to kidney failure, all right, if our kidney is sick or have a problem. Now let's talk about bone formation. Again, kidneys also play a crucial role in maintaining bone health, okay, through the involvement of what activation? What does it activate again? Okay, it activates inactive vitamin D, okay, which is our calcidiol, into its active form. We call this one calcitriol. All right, calcitriol is a hormone that plays a vital role in what absorption again? Okay, calcium absorption from our intestines. When calcium levels in our bloodstreams are low, okay, our parathyroid glands will release parathyroid hormone, okay, that will stimulate the kidneys to produce calcitriol or active vitamin D, therefore promoting absorption of our calcium from our GI tract. Ensuring, okay, we have adequate supply of calcium for our bone health. Okay, so very important also kidneys for bone strength or bone health. What about our EPO or erythropoietin? Okay, kidneys, okay, secretes a hormone called erythropoietin or EPO, okay, to synthesize, all right, or to produce, okay, I mean to stimulate our red bone marrow to produce red blood cells. Red blood cells is needed for what? What does it do with our body? red blood cells. It gives our body oxygen and energy. All right? For tissue perfusion. Problems with the kidney, can we have problems with RBC production? Yes, that's why you see in hemodialysis patients, what do they receive? Have you heard about EPOGEN? Yes, okay. To prevent anemia, all right? For tissue perfusion. For electrolyte balance, okay, sodium and potassium, if it's low, okay, what's the normal sodium level? 135 to 145. What about potassium? Potassium, 3.5 to 5 or 5.1. If it's low, okay, the kidneys will reabsorb up to balance or normal levels. If it's too high or too much, the kidneys will excrete excess sodium and potassium. Aside from that, additional electrolytes will also be reabsorbed and excreted depending on its imbalance. All right? So keep in mind, calcium, potassium, sodium, okay, phosphorus, all right, magnesium, all of the electrolytes, okay, will be filtered or will be eliminated by the kidneys depending on its imbalance. Acid-base balance, okay, decreasing in kidneys will excrete hydrogen ion, okay, because hydrogen ion, guys, is acid by nature. All right, it will excrete excess hydrogen ions if we have a decreased blood pH. Meaning, what does our body have if we have a decreasing blood pH? Acidotic or alkalosis? Of course, we have acidosis, regardless if it's respiratory or metabolic. Okay? If we have a decreased blood pH, hydrogen ions, okay, will be excreted because it's acid by nature. And we are already acidosis here. So might as well excrete that one. Now, if the kidneys will reabsorb hydrogen ions, it means we have, okay, an increased blood pH. What do we have? What imbalance do we have? Alkalosis. All right, we have alkalosis. So later, I will give you some examples so that we can review our ABG. Okay, if we have extra time. Nitrogenous waste, okay, kidneys play a crucial role, of course, in the excretion of our nitrogenous waste from our body. Okay, these are our urea, creatinine, uric acid, okay, by, of course, who metabolizes the protein? What organ metabolizes the protein? Can you still remember? Our liver. Okay, once the protein is metabolized by the liver, what's the byproduct first? What is the byproduct? Okay. The byproduct would be ammonia. Ammonia is toxic to the brain. Okay, that's why it is needed to be eliminated, okay, by converting ammonia into urea, okay, which will then eliminated by the kidneys, okay, via our urine. All right. Now, problems with kidney, not just problem with the liver, problems with the kidney. What kind of diet are we going to give to the patient? General problems by the kidney. What kind of diet to prevent ammonia and urea? Of course, low protein diet. Can you give me examples of high protein rich foods that must be avoided? Meats, what else? Red meats, of course, very important. Eggs, okay. Beans, those are examples of our protein, okay, that must be avoided by clients or patients with kidney problems. Is this clear? Is this part clear? Nitrogenous waste excretion. Do you have any questions with this one? Okay, now, just a quick review lang of our nephrons. Okay, nephrons is the functional unit of our kidney responsible for what function? What does our nephrons do? What does it do? For filtration. So for filtering our blood, for removing waste products, for regulating electrolytes, and for maintaining fluid balance. Let me write. Filters blood, removes waste products, regulates electrolytes, and maintain fluid balance. So based from the picture, okay, each kidney contains 1,000,000 of nephrons, okay, making them functional for our body. All right, so here we have our, of course, glomerulus. Okay, these are network of capillaries or tiny blood vessels where blood is initially filtered. Okay, now this is found in what capsules? Start with the letter B. What do we call that capsule? Bowman's capsule. Very good. Bowman's capsule, as you can see, it's like a cup-shaped structure that surrounds our glomerulus. So it collects the filtrate, okay, the fluid and the waste products that is initially filtered. So initial filtration happens there in your glomerulus. Now we have what we call our proximal tubule, our loop of Henle, and our distal tubule. Proximal tubule, all right, is responsible for reabsorbing essential substances such as our glucose, amino acids, sodium, and water back in our bloodstream. All right, so that's the first filtration. All right, so that's what we reabsorb. The loop of Henle, all right, it's like a U shape, as you can see in the picture, all right. It consists of descending and ascending limb, all right? So it also plays a role in concentrating our urine by reabsorbing water and electrolytes. For our distal tubule, all right, so this is the last tubule, all right, this is also responsible for reabsorbing or secreting ions, okay, as well as regulating our blood pressure. So it also works together with excess electrolytes such as our sodium or our potassium. And lastly, we have our collecting ducts, all right? Collecting ducts, all right, are multiple nephrons as well, okay, which serves to collect urine, all right? So this is just a quick summary of our nephron filtration and removal of waste products. So this is just a guide, all right? Now, what does your NCLEX ask you aside from the functions of your kidneys, all right, or your nephron? Okay, it also is responsible for also we need to know first the diagnostic procedures, all right? Diagnostic procedures commonly related to kidneys. We have our IVP and your renal angiogram. Are you familiar with this one? Intravenous pyelogram and your renal angiogram. Okay, so when you say intravenous pyelogram or IVP. This is a diagnostic imaging test, okay, that is used to visualize, all right? IVP is used to visualize our kidneys, ureters, and our bladder. Okay, so commonly performed to assess our urinary tract if we have certain kidney stones, if we have blockages in the kidneys, or if we have tumors, and even other abnormalities. So that's how our IVP is needed. All right, so in preparation, okay, as you can see, there's a small picture here. Okay, the patient will be positioned supine. Okay, and then, all right, the patient may be asked to fast, all right, for a few hours. So 6 to 8 hours, all right, because a contrast dye, all right, usually it's iodine based, is injected intravenously. Hence, we call the name is intravenous pyelogram. All right, so IV contrast dye injection, okay, which will highlight, all right, our urinary structures via X-ray images. So gram, when we say gram, okay, with the use of our X-ray. So injection first, okay, of our iodine-based contrast dye, and then X-ray imaging for visualization of our kidneys, ureter, and bladder. In case there are kidney stones, blockages, tumors, or other abnormalities. Now, before, all right, the patient would be asked for allergies to seafood or shellfish, all right? But I think it's already updated. Okay, allergies to seafood or shellfish would be no longer recommended as options, all right, for assessing to the patient if he or she will be receiving contrast dye. So what will you be asking to the patient is allergies to iodine itself. Is this clear? Because in my time, when I took my NCLEX, shellfish or seafood are still considered. But now, it's no longer considered. Just an update. So what will you assess again? Prior to the procedure, everyone, what will you assess or what will you ask to the patient? If there are any allergies to iodine itself. Is this part clear? This update? Okay, good job. Take note of that one, okay? Of course, for better visualization, we can do cleansing enemas, all right, as well as NPO prior 6 to 8 hours. After the procedure, all right, after the procedure, the patient may be asked, okay, to increase oral fluid intake. Why do you think so? Why do we need to tell the patient to increase fluid intake? Ma'am, sir, drink more water, okay, in order to flush, all right, or to facilitate excretion of the contrast dye. Now, if you didn't assess allergies to iodine, okay, what would be the complication? If the client is allergic to iodine and then the client had IVP, what would be a complication for the client? Which is fatal, anaphylaxis or anaphylactic shock, okay? This is for IVP, okay? For renal angiogram, okay, again, this is also an imaging procedure, okay, that is used to visualize blood vessels in the kidneys, all right? So renal angiogram, okay, is an imaging procedure used to visualize blood vessels in the kidneys. All right, so this kind of test would provide detailed information of how our blood flow, okay, to or within the kidneys to evaluate certain conditions related to our kidney problems or kidney diseases or disorders. Same thing, the client will be positioned supine. Okay, would there be a contrast medium present as well? Would there be contrast medium present or iodine? Yes, okay. But this time, these are inserted, okay, via our femoral artery. Okay. So what we will be needing would be local anesthesia. Sorry, kindly include their local anesthesia. Okay. Prior to the procedure. Okay. And of course, would you be needing to assess for allergies to iodine for the patient? Yes, okay. So there will be a catheter, okay? If IVP is injected IV directly, for your renal angiogram, there will be catheter insertion, okay? Through a small incision, usually in your groin or in your wrist or even up to your femoral artery. So this is carefully guided through your blood vessels toward your renal arteries, which supplies the blood in your kidneys. So same thing, NPO 6 to 8 hours. Post renal angiogram, of course, tell the patient to increase oral fluid intake, all right, to facilitate flushing of the contrast dye and straighten the legs for at least 6 hours. Why do we need to tell the client to straighten the leg for at least 6 hours after this one? What can happen? We are visualizing, okay, our renal artery, which can be inserted in our femoral artery, and artery is highly vascular. So what can it create? Why do we need to straighten the legs? Okay, aside from bleeding, okay, if there's any obstruction, okay, in one part or in one tissue, if you didn't straighten the leg, okay, there can be one side of your body or one side of your limb, okay, that will pull so much blood and can create what? Clot or thrombus formation. Okay, do we want that one? Of course, we don't want that one. So complications, aside from anaphylactic shock, check for bleeding and absent distal pulses. All right, so this is for your renal angiogram. So these are just two common diagnostic procedures related to your GUT. Okay, these two common diagnostic procedures. Do not forget this one. Again, assess for allergies to iodine already. Iodine itself, not no longer seafood or shellfish. All right, so let's discuss the first disorder of your kidneys, which is your renal failure. Renal failure can be divided into two. We have your, what type of renal failure? Types of renal failure. We have your acute and your chronic. Okay, acute is more of a short or long term. How about reversible or irreversible? So this is more of reversible. Usually 6 months less. Less than 6 months. Okay? So acute renal failure, okay, also known as acute kidney injury. It's the same thing. Okay? This is sudden, abrupt, or even short-term reversible loss of kidney function. So it has different or various causes. As you can see here, we have different types. We have pre-renal cause, we can have intrarenal cause, and we have post-renal cause. All right? When we say pre-renal causes, okay, can you give me examples? What are being said here? Pre-renal causes. What are the examples? Dehydration, shock, burns, dysrhythmias, hypovolemia. What I want you to remember, okay, to summarize pre-renal causes, these are conditions, okay, that reduce blood flow to the kidneys. Okay, impairing, of course, its ability to filter the blood effectively. Hence, we have the following: hypovolemia, dehydration, shock, burns, dysrhythmia. All right. So this will probably cause decreased blood volume and reduced kidney function or perfusion. So do not forget this one. When we say intrarenal, okay, from the word itself, intrarenal, all right, this involves damage or injury to the structures of the kidney themselves. So within the kidney structure impairment. Okay. Example, we have your acute glomerulonephritis. All right. So this is the inflammation of your glomeruli or the filtering units of your kidneys, which will lead or which can lead to acute renal failure. We can also have your nephrotic syndrome, okay, which there will be damage, okay, in your filtering part as well, and nephrotic drugs, all right, that is toxic to the kidneys. Nephrotoxic drugs, example of that one would be your aminoglycosides. These are examples of drugs that are toxic to the kidneys, all right, so one of your intrarenal causes as well. When we say post-renal, okay, just remember these causes involves obstructions or blockages. Post-renal obstructions or blockages in the urinary tract that would actually prevent the normal flow of your urine from the kidneys. Hence, may also be a cause of your acute renal failure. What can be example of obstruction or blockage? All right, we have the following. We have your prostate cancer, all right? So there's two more. We have your BPH. What is BPH, guys? What is BPH? We call this one your benign prostatic hyperplasia, all right? So your prostate gland is obstructed, all right? Renal calculi or renal stones. So of course we have the common, okay, kidney stones, okay, that can also block the flow of urine from the kidneys. So to summarize, pre-renal cause, poor perfusion, so decreased blood flow to the kidneys. Intrarenal cause, any problems within the kidney itself, either it's infection or inflammation or even toxic drugs that will damage the kidneys. Post-renal cause, obstruction or blockages, whether it's cancer, whether it's tumor, or whether it's stones. Is this clear? Causes of acute renal failure? Guys, is this clear? No need to memorize. Just remember, pre-renal, above the kidney problems, intrarenal, within the kidney problems, post-renal, after the kidney problems. Okay, tell me if it's pre, post, or intra. Shock. Pre, BPH. Post-renal. What about urinary calculi? Post, dysrhythmia. Pre-renal. Aminoglycosides. Intra. Nephrotic syndrome. Intrarenal. Glomerulonephritis. Intrarenal. Is this part clear? The causes of your acute renal failure. Is this clear? Yes. Okay. Let's now move with the stages. Okay, ma'am. Since I already know this, the causes of my acute renal failure, all right, let's discuss the stages, all right, of our ARF or acute kidney injury. So we will start off first with the oliguric phase. From the word itself, oliguric, what do we mean by that one? Oliguric. A patient is oliguric or experiencing oliguria. What do we mean by this one? What do you mean by oliguria or oliguric phase? This is your first stage of your acute renal failure in which there would be decreased urine output. Okay. What is 30 cc times 24 hours? That's roughly 720 ml per day. Is that your normal urine per day? Expected normal urine per day? Yes. Okay. Now, if you have acute renal failure, expect, okay, that the patient, upon oliguric phase, okay, there will be significant decrease in the urine output. Usually, okay, defined as less than 400 ml per day or 400 cc per day. Okay. So this phase actually occurs within few days to a week, okay, after the injury of your kidneys. So what happens, okay, decrease urine output, okay, since this is oliguric phase, this is the hallmark sign, all right? The hallmark sign of your oliguric phase, if it's less than 400 cc per day, or if there's already significant reduction in the urine output. Now, would this lead to fluid and electrolyte imbalances in the body, our oliguric phase? Yes. Okay. Now, since we cannot urinate normally, okay, would there be chances that our fluids will be retained? Yes. Okay. Now, fluid retention, of course, due to the reduced ability of our kidneys to eliminate excess fluids, fluid retention can occur. Now, what is the effect of that one in the patient's body if there's fluid retention? What will happen to the blood pressure? Okay, blood pressure would be increased. Would there be chances of edema or swelling? Yes, so edema, particularly can see it in the legs, ankles, and other parts of the body. Okay, so as a management for the client, if it's fluid retention, as nurses, what are you going to do as a management? If there's edema and high blood pressure, yes, you can give your diuretics. What else? Limiting of fluid intake. Okay, now, would there be chances that hydrogen ions, okay, hydrogen ion, okay, won't be excreted if we have acute renal failure? Decreased excretion of our hydrogen ion. Is hydrogen ion an acid? Yes or no? Yes, by nature, it's an acid. So if there is decreased excretion of hydrogen ions by the kidneys, what metabolic imbalance can it lead to? Okay, so add in your notes, all right? Add in there will be possibility of metabolic acidosis. That can arise or that can happen in the oliguric phase or in your acute renal failure. Metabolic acidosis. Is this clear? Is this clear? Fluid retention. Okay, now let's move on with your glomerular filtration rate. Now, with your acute renal failure, of course, there will be also compromise with the filtration rate of your glomerulus. Since your kidney is injured, okay, it won't be able to filter properly or normally or smoothly. Okay? GFR will be slowed down. Okay? Now, if the filtration rate is slowed down, all right, or decreased, what will happen? Would you be able to retain excess waste products, excess electrolytes? Yes or no? If it's slowed down. Yes, a lot of waste products, a lot of excess electrolytes will be retained in the body. Is that a problem? Yeah, so what will happen to the BUN and creatinine? High or low? Of course, it will be retained. So it will be increased. Can you give me the normal levels of your BUN? 10 to 20. What about your creatinine? 0 point what? 0.62 what? Creatinine, what's the normal level? 0.6 to 1.2. Very good. All right. Now, would there be chances that we might as well can reabsorb electrolytes such as potassium and sodium? Can we disrupt the balance of our electrolytes? What will happen to the level of your potassium? Increase. What happens to the level of your sodium? Increase as well. So between sodium and potassium, which one is more fatal? Of course, your potassium. All right. Now, aside from that, BUN, creatinine, okay, expect also that we can also um retain, okay, our nitrogenous waste. Nitrogenous waste. All right, such as our urea, okay, that can be built up in the bloodstream. All right. So we can have problems with letter A. Okay, what do we call that letter A? If there will be accumulation of waste product. Azotemia. Okay, we call that one azotemia. Accumulation of waste products in our bloodstream. All right, leading to uremia or even altered level of consciousness. So in some cases, that can also happen in the oliguric phase of the patient. All right, so let's manage our diet. Okay, if you know already that this can happen in the client upon oliguric phase, okay, what would be our best diet when it comes to protein, high or low protein diet for the patient? What's the best diet? It should be what? Of course, low protein. What about potassium-rich foods? Okay, low potassium-rich foods. Can you give an example of potassium-rich foods that must be avoided? Banana, avocado, watermelon, strawberries, all right? Salt substitutes. Salt substitutes are rich in potassium. Give or don't give. Okay, we do not give salt substitutes. What about sodium intake? Low sodium intake and of course fluid intake. What do we do with fluid intake? limit fluid intake. Okay, do not restrict, just limit. All right, limit fluid intake. Now, since acute renal failure is reversible, okay, now it will try to compensate, all right, through the goal of recovery. Okay, it will undergo first diuretic phase. So after oliguric, okay, you will check that the kidney is trying to recover, all right. So there will be diuretic phase. Now, when it comes to diuretic phase, what is now happening in the client? What is your hallmark sign if it's diuretic phase? What will you check with the patient? Diuretic, meaning, what do you mean by this? Diuretic. Okay, very good. There will be a significant increase of urine production, okay, compared to your oliguric phase. So, patients may produce large volumes of urine, okay, often, of course, exceeding the normal urine output, okay. So this will eliminate the accumulated waste products and excess fluids from the body. However, our priority, okay, even though we are releasing excess fluids, releasing electrolytes, a lot of waste products, our priority for the client, if it's polyuria or diuretic, of course, is dehydration. Okay, so is it important to check the input and output of the patient, both for oliguric and diuretic phase? Of course, all right. Is it also important to check if the client is improving by checking the level of consciousness as well? Yes, okay. Now, this is already your transition to recovery, all right? If it's already recovery phase, okay, the context of your recovery phase with acute renal failure or acute injury, okay, is to check if it's already within the normal levels. You would be able to know that the client is already in the recovery phase if the BUN, the CREA, the potassium, the sodium, and other electrolytes are within the normal levels, as well as the urine output. What's the normal urine output? 30 ml per hour. Okay. And of course, 720 and above, okay, ml per day. All right, so that is already within the recovery phase. Now, did the patient recovered already? Acute renal failure. That is why this is your short-term or your reversible problem. Is this part clear? Do you have any questions with acute kidney failure or acute kidney injury? Do you have questions with this one before we proceed with the next? Guys, do you have questions? Okay. Now, let's try to discuss naman our chronic. When we say chronic, what do we mean by chronic? Chronic renal failure. When we say chronic, okay, this is more of gradual, all right, or progressive condition. Is this reversible or irreversible? Long-term or short-term? Okay, now, we can have different kinds of chronic renal failure, all right, depending on the kidney's function or compensation and damage. So when we say reduced renal reserve, our kidneys damaged, 75% of our kidneys are damaged. Therefore, the kidney can only function 25%. Okay, although this is asymptomatic. Renal insufficiency stage, okay, the damage is roughly 75 to 90% of our kidneys. compensation is 10 to 25%, meaning the normal kidney function is just 10 to 25%. As for your last stage, we have your end-stage renal disease or your ESRD, wherein our kidneys damage is 90% or the whole kidney itself. So compensation of your kidney is just either 10% or below. All right. At this stage, when you say end-stage renal disease, okay, are these people candidates for kidney transplant and dialysis? ESRD stage. Yes, all right. These are the people you see in the dialysis centers, all right? Or even in kidney hospitals for kidney transplants, okay, for your ESRD. Can you tell me what are the causes? Why did we have end-stage renal disease or even chronic renal failure? Can you give me examples of the factors that causes CKD or CRF? Hypertension, very good. What else? What other diseases? Aside from high blood pressure, diabetes mellitus. Okay. Glomerulonephritis, very good. Okay. Autoimmune diseases, all right, or even medications that can harm the kidneys or that can damage the kidneys. What about recurrent or repeated UTI? Can that also lead to kidney damage? Yes, all right. Now, as nurses, are we common to having UTI? Why? Why do you think so? Yes, of course. We don't have time. We're so busy, right? We always work in the hospital. Our patients are our priority. So less of our priorities are bladder. So we can have UTI, right? We are at risk pala. We are at risk for having UTI. Therefore, repeated or recurrent UTI, this can lead to chronic renal failure. So when you become a USRN already, when you go to US, your priority is your bladder. Okay? So tell your head nurses, okay, I don't want to have end-stage renal disease someday. So, of course, it's your right to take a bladder break. Okay, now, can you still remember the functions of your kidney? What's our mnemonic for kidney functions? Our bean. Okay, so when we have chronic renal failure, expect that bean functions of our kidneys, these bean are all compromised. Okay, starting off, of course, with your blood pressure, chronic renal failure, what can happen? What can happen to the patient? Okay, expect that a patient with chronic renal failure has hypertension or high blood pressure as a common complication of your chronic kidney disease. Of course, controlling our blood pressure is essential, okay? However, if you have kidney damage, okay, this will be compromised. So check for high blood pressure. What about your bones? What will happen to our bones? Since our kidneys are damaged, okay, expect that our bones will become brittle, okay, or softened, weakened. We call this one, if it's secondary to kidney disorder, we call this brittle bones disease renal osteodystrophy. All right, because it is related or it can be caused by kidney dysfunction. All right, so renal osteodystrophy. What about your erythropoietin? What can happen to the patient if this is no longer produced by your kidneys? Anemia, very good. What about electrolytes? What can happen? Do we retain or do we excrete electrolytes? we retain electrolytes. So we have hyperkalemia, hypernatremia, hypermagnesemia, all right? Hyperphosphatemia, include that one as well. What about acid-base imbalance? What kind of acid-base imbalance if we have chronic renal failure? Of course, due to retention of our hydrogen ion, we can have metabolic acidosis. So as a response, okay, or as a compensation of our client, if a client is experiencing acidosis, metabolic acidosis, he or she can breathe like deep and rapid. We call that one Cosmos breathing. It's like the patient is experiencing DKA. It's the same kind of breathing, Cosmos breathing, because the patient is trying to expel acid, right? Excess acid in the body. And since carbon dioxide is an acid, okay, so we try to do Cosmos breathing by excreting or expelling excess CO2, which is an acid. So that's your Cosmos breathing as a compensation, guys, for metabolic acidosis. What about your nitrogenous waste? If it's accumulated in the blood, what do we call that again? Accumulation of nitrogenous waste, we call that one your azotemia. What will be retained in the body? What are the wastes that are retained in the body? Urea, BUN, CREA, okay? And of course, this can also lead to renal encephalopathy. Renal encephalopathy, which is already, okay, or which waste products have reached what area of our body? If it's renal enceph, our brain. Okay, so expect that the client's level of consciousness will what? Will be altered or decreased. Okay, there will also be in cases of uremic frost. When you say uremic frost, I'll show you a picture. Accumulation of uric acid in the skin. All right, so this is related to your azotemia. Okay, so there are chances in which chronic renal failure patients, okay, you can see this kind of patients, these are very uncomfortable because this really can cause itchiness or pruritus, and it's very smelly. Okay, this one, the uremic frost. It's like your urine is being retained in your skin. So just imagine that one. Your urine is retained in your skin. That's your uremic frost. Now, do you want to have chronic renal failure? Okay. To prevent chronic renal failure, what must you do, nurses? Because we have lots of manifestations here. What can you do as a prevention first before management? Healthy diet and lifestyle. Always P. What else? What kind of diet? Some jupe once a month only. Not every day. Low fat, low sodium, right? Green leafy vegetables. Okay. Less of red meats, less of pares, less of sisig, crispy pata. Okay, less of those things. Of course, hydrate. Okay, less caffeine, more water. Okay. Mas mahal daw po yung gulay. Management for high blood pressure. Guys, management. What we've discussed a while ago, how can we manage hypertension? Antihypertensive drugs such as your beta blockers, your ACE inhibitors, your ARBs. Okay, the one we've discussed a while ago. All right, in your RAAS. What about brittle bones? How can we manage brittle bones? We can give, of course, calcium-rich foods and vitamin D-rich foods. We can also give your amphogel, okay? Remember, Amphogel is an antacid, but it's also a phosphate binder. Okay, meaning it binds with your phosphate. Okay, so when your phosphorus or your phosphate goes down, your calcium will go up because they are inversely proportional. All right, so we can provide this one as well. Aside from calcium-rich foods and vitamin D-rich foods. What about anemia? How can we manage anemia? Okay, your epogen. How about your excess electrolyte? All right, so we can give for hyperkalemia your kayexilate. Okay, together with your IV insulin plus your glucose. Okay, because insulin can put potassium back together with your glucose, okay, back to your cells. So it will decrease your glucose level. So you might as well balance it. All right. Decrease potassium diet. So what are the things that we might decrease, as well as sodium diet? What are the things? Can you give examples of foods that must be restricted or avoided? What kind of foods? Processed foods, salty foods, all right? So would you opt to choose healthy, heart-healthy foods such as fatty fish, salmon, olive oil, cooking? Mamang mahal nun. It's very expensive. Avocado. So limit also sugar and carbs. All right. If there are cases that the cause is DM, all right, high blood sugar levels, we have to manage DM as well. Acid-base imbalance, how can we manage this one? Acid-base imbalance. Metabolic acidosis, how can we manage? Of course, we neutralize by giving your sodium bicarb. What about your azotemia? Renal NSF, uremic frost. Since you know the cause of this one, so what kind of management? What will you tell the patient to limit? Okay, reduce protein intake, particularly high quality of protein to help lower the workload of your kidneys, of course. All right, this is very essential. Low protein diet. What time is it? 2:30. All right. So again, this is your uremic frost. Okay, accumulation of urea and waste products that deposited in your skin. If it's in the bloodstream, concerning, of course, your level of consciousness as well, crossing the blood-brain barrier, we call that one your azotemia. Now, is this patient needing dialysis already? If it's already like that, of course, very important. What is the purpose of dialysis in your body? Our dialysis, what does it do? Okay, so very good. Okay, our hemodialysis, do we use a machine here? A dialysis machine that is, okay, used for what? For special filtration, which can be used as our artificial kidney because our kidney is already damaged. So it will be used as our alternative. Okay, so the machine itself will be our kidney together with the dialyzer to clean your blood. Now we have different access site when it comes to hemodialysis. We have your permanent access, your AV fistula, or your AV graft. We also have your temporary access, such as your central venous catheter and your AV shunt. So internal would be your permanent. Okay, external would be your temporary access. So AV fistula, we call this one your arteriovenous fistula. Okay, so as you can see in the picture, this is a surgical connection, okay, between your artery and your vein. So the doctor will surgically connect the artery and the vein, okay, usually in the forearm or in your upper arm. AV graft. Okay, when you say AV graft, this is also a surgical procedure creating a connection between an artery and a vein using a synthetic tube. All right, to bridge the gap between your artery and your vein. So this is more used for immediate access and long-term durability. So used after 2 weeks. For AV fistula, it will take time to mature, so you still have to wait for more than 2 weeks, so 4 to 6 weeks. Temporary access, we have your venous catheter, okay, or your CVC. So this is inserted into a large vein in your neck, in your chest, or it can also be in your groin. Okay, so this is more of a short-term or temporary access to your circulatory system during hemodialysis. So this is more of emergency cases. Okay. However, you have to check because the client may have higher risk of infections and other complications for the CVC. AV shunt, when you say AV shunt, this is your arteriovenous shunt. So this is surgically created also between artery and in your vein. So it's the same thing, however, this is more of external. It's like your AV graft. Okay? So it's also used for emergency situation. I'll show you a picture. So the first picture, this is your AV fistula. So it's connected. AV graft, this is the second picture. So it's internal. Yes, ma'am, it has a tube as well for AV shunt. So AV fistula, if it's inside the patient, so this is how it looks like. AV graft also inside the patient, this is how it looks like. For AV shunt, yes, ma'am, we have a tube as well. So, but this is more of external. And this is your CVC. Now, ma'am, what does the NCLEX usually ask when it comes to hemodialysis? Of course, our nursing management. So you may copy this one, all right? For internal access, AV fistula and AV graft. Very important, you have to monitor the access site for any signs of infection such as redness, swelling, warmth, or purulent drainage. Assess also for signs of clotting or thrombus formation, which may impede the blood flow. All right. So to check for patency, all right, we auscultate for what we call bruit. Okay, when we say bruit, this is the whooshing sound. All right, this is the audible whooshing sound. And we palpation of your thrill. Okay, when we say thrill, this is the vibrating. Okay, vibrating feeling, okay, when you lightly palpate the patient's arm, right, or access site. So you will know if it's patent if there's bruit and thrill. Again, do not interchange this one. For proper blood flow and patency, audible sound, auscultate bruit, palpate thrill. All right, so ABPT. Okay, auscultate bruit, palpate thrill. Avoid blood pressure measurements, venipunctures, or IV infusions in the arm, okay, in which the AV graft or AV fistula is placed, all right, to prevent damage to the access site. So this is very important. You do not take blood pressure or venipunctures or even get blood samples on the affected site. Educate the patient on the importance of protecting the access arm or avoiding trauma or pressure on the access site. So safety precaution as well. Now, for improvement in the blood flow, okay, and maintaining the access site healthy, we can exercise, okay, but only isometric. All right, isometric exercises. What are the examples? So we can have the stress ball. So you may squeeze that one. So squeezing your soft ball or even hand grip exercises. So these are common isometric exercise. Of course, do not also forget to encourage regular monitoring and assessment, all right, by other healthcare team. Of course, this is very important to address any issues promptly. So report any signs of infection, any signs of trauma, any signs of and symptoms to your doctors, especially to your renal, cardio, and other healthcare team. Perform regular access flow assessments. This can be used by using a Doppler sound, okay, and other flow-related problems. But these are just additional, all right? This is just additional management for your AVF and your AVG. Do you have this in your handouts? Guys, is this included? I just added this one. Sige, screenshot nyo na lang. Just take a screenshot. Guys, this is also managed, this can also be applied to your AV shunt as well. AVF, AV graft, AV shunt. Because all of these are using your forearm. Let me know if you're done. Okay. Now for your central venous catheter, again, this can be used for emergency purposes. So as a management, of course, we maintain a strict aseptic technique, okay, and dressing changes. Our goal also is to prevent infection, minimizing the risk of infection, okay, changing the sterile dressing and secure CVC in place as per hospital protocols. Routinely assess the insertion site for redness, swelling, tenderness, or signs of infection. Monitor for any CVC-related complications, such as thrombosis. So this can cause actually a risk for blood clot. So monitor for that one. Flush the CVC lumens with heparin or saline as ordered, okay, to keep them patent and prevention of clot formation. Educate the patient on CVC care, including proper hygiene, signs of infection or complications, and reporting of any issues. And of course, collaboration with other healthcare teams. So screenshot as well this one. You can screenshot this one as well. Usually, in general, when it comes to hemodialysis, the NCLEX would be asking you nursing management. Okay, the NCLEX won't be asking you to draw AV graft, AV shunt, AV fistula, but your nursing management. Also, of course, this one, checking of your patency or good blood flow. So do not interchange this one. Auscultation of bruit, the whooshing sound, and palpation of thrill, the vibrating feeling or vibration. So this is how the hemodialysis works in your body. So this is just a summary, okay, of the management. No BP, no venipuncture, no IV infusion on the affected site, no cardiac glycoside or your digoxin to prevent toxicity, because this can be a risk for digoxin toxicity, high levels of digoxin in the bloodstream. All right, so no of digoxin. Squeezing of rubber balls, stress balls, hand gripping for your isometric exercises to improve your blood flow. Aside from this one, all right, so generally infection, patency, improvement in blood flow. Also, you have to check the level of consciousness of the patient. Okay, this is very important, especially if the patient is first timer for hemodialysis. Are you familiar with this one, the DDS, dialysis disequilibrium syndrome? Have you heard about this syndrome? Yes. Okay, what is this? What happened? What is dialysis disequilibrium syndrome? What happened to the patient? Yes. Okay, very good. If patients are new to dialysis, okay, um the removal of waste products and excess fluids from the blood is rapid, results from rapid removal, okay? And this can manifest symptoms related to cerebral edema or brain swelling. So what will be important to check for the patient if the patient is experiencing dialysis disequilibrium syndrome? What will you do? Very important assessment is to check what? Is to check any alterations, okay, in the level of consciousness of the patient. Nausea, seizure, restlessness, headache, confusion, irritability, okay? So any decrease in the level of consciousness, that may indicate, okay, symptoms of your dialysis disequilibrium syndrome, especially if patients are new to dialysis. So this is a reportable complication of your hemodialysis. Now, how would you prevent this syndrome? As nurses, what are going to do? Aside from reporting to the doctor, what will you do? What can we do to prevent this one? If this is rapid removal, so what will you do? Guys, all right. Slow down the rate of dialysis. Okay, that's one way to prevent this one. Do not stop, but slow down and then report. All right? Slow down, not stop. Okay, slow down and report. All right. You cannot stop right away because the client is undergoing hemodialysis. If you stop right away, there might be possible complications that can arise as well. All right. So slow down and report. Okay, for dialysis disequilibrium syndrome. If you can see in some hospitals, dialysis centers, they usually stop it. Book-based tayo, so slow down the rate. Is this clear? Okay. All right. Now, another form of dialysis is peritoneal dialysis. Are you familiar with this one? This is also dialysis, but this is more with the use of your peritoneal cavity. All right. However, can I ask you who are contraindicated with peritoneal dialysis? If we are going to use our peritoneal cavity, who are contraindicated? Who are those people? those, just remember, okay, we are going to use peritoneal cavity, right? For filtration and for infusion. Therefore, we have to prevent doing this to patients who have abdominal problems, all right? Such as your Crohn's disease, ulcerative colitis, right? Inflammatory bowel diseases, all right? End-stage liver disease, those that have ascites, okay? So you do not give this one as well. This is very dangerous for them. All right. So do not use this one to these kinds of patients. Just remember, any abdominal problem the patient has, peritoneal dialysis is contraindicated. So this is also another form of renal replacement therapy for individuals with end-stage renal disease. So unlike hemodialysis, this can involve the use of this won't involve the use of external machine to filter blood. Okay, so just the patient's peritoneal membrane as a natural filter. Advantages for this one, it may allow more flexibility and independence compared to in-center hemodialysis. In some cases, this can be done at home. Fewer dietary restrictions, as this is a continuous process, and no need for AV graft, AV fistula, AV shunt, all right? Fewer cardiovascular side effects compared to hemodialysis. So this is your peritoneal dialysis advantages in comparison to hemodialysis. Now, what are the components, okay, of your peritoneal dialysis? Here in the picture, we have your peritoneal catheter, all right? This catheter is a flexible tube that is surgically placed in the abdomen, okay, to access your peritoneal cavity. This is where you're going to infuse and this is where you're going to drain, okay, the dialysis fluid. The dialysis fluid, we call that one your dialysate. Okay, this is actually a sterile solution that contains glucose and electrolytes. So your dialysate have electrolytes and glucose, okay, that will be infused or introduced in the peritoneal cavity for facilitating removal of waste products and excess fluids. All right, so these are the components for your peritoneal dialysis. Now, in performing this one, okay, usually what you're going to check would be the time. So infusion, 2 liters of dialysate solution, usually 10 to 15 minutes infusion time. All right. When you say dwelling time, you have to wait, okay, for several hours. This is the time in which the solution stays in the patient's peritoneum. So you have to wait, all right, to dwell inside the peritoneum. Now, too much dwelling, okay, this can actually cause hyperglycemia because your dialysate contains glucose, right? So what will be your antidote for hyperglycemia, guys? So checking of blood glucose, you suspect there's hyperglycemia, so it might be too much dwelling. So antidote would be insulin. Draining time, all right, this is the time, same thing with your infusion, but this time this is the time the solution will be drained out. So same time, usually happens 10 to 15 minutes. So if you suspect that there's too slow draining, so we can turn the patient side to side for movement, okay, of the fluids. So turning the patient side to side. Now, is this invasive? Yes or no? Is this an invasive procedure? Yes. So, as nurses, what would you report to the doctor? Report signs of infection. Report also drainage color if it's cloudy. Okay, take note. If the drainage solution is cloudy, all right, after peritoneal dialysis, you have to report it because this may indicate signs of peritonitis. What is peritonitis? Itis, what's that? Inflammation of your peritoneum. Is this clear? Report signs of peritonitis. What kind of drainage? Cloudy. All right. Okay, so take note of this one. All right, so sige. Before we proceed with your kidney transplant, let's have a break first. 15 minutes. Would this be okay? Okay. All right, so can we continue? Or did we stop? Kidney transplant for a while. Okay, so kidney transplantation, guys, is another management, okay, aside from hemodialysis patient for end-stage renal diseases. So this is actually a surgical procedure, okay, from which a healthy kidney from a living or deceased donor is implanted into the recipient's body. So as you can see in the picture, before and after kidney transplantation, so your kidney will now be placed, okay, in your iliac fossa, in the transplanted donor kidney. So here's a picture here, and that's how it will look like. So the deceased kidney, all right, will be removed, but the kidney will be placed not on the same anatomical position, but near the iliac fossa. So for cases of kidney transplant recipients, okay, since this is a surgical procedure, removing the kidney, okay, from the donor and implanting it into the recipient's lower abdomen, okay, the recipient um own kidney, okay, can be left in place unless, all right, they are causing complications such as infection. So usually it can be retained there or it can be removed, all right? But when you do kidney transplantation, it is very important that the recipient would be prescribed of immunosuppressive medications. Take note of this one, all right? To suppress their immune systems in response to prevention of rejection. When you say rejection, what do we mean by that one? What do you mean by transplant rejection? Okay. The reason why, okay, we are receiving immunosuppressants is because we want to suppress our immune system. Because, of course, a donated kidney, all right, or the transplanted kidney, sometimes in people who had this surgical procedure, might, okay, attack the foreign body or might confuse the body, okay, of the transplanted kidney as a foreign entity or foreign body. So it will create its own antibody against that transplanted kidney. So we want to suppress our immune system by giving our cyclosporin or your sand immune. Okay. You can take it with chocolate milk, orange juice, but never with grapefruit juice because it might lead to toxicity. So this is for prevention of acute rejection. There can also be complication in which the kidney can be dislodged. All right. So what are the things that you must tell the patient, okay, to prevent risk for dislodgement? What will you tell the patient to prevent risk for dislodgement? Avoid what? Avoid contact sports. Very good. What else? Avoid heavy lifting. Good. What else? Okay. In general, Good job. Vigorous exercises must be avoided to prevent dislodgement or displacement. Remember where your transplanted kidney are already in place. Okay, it's in the iliac fossa. So anything that would dislodge, okay, from this area, avoid activities, especially lifting heavy equipments, vigorous exercises, or contact sports. For acute rejection, okay, we give your immunosuppressants. Now, how would we determine, okay, if the patient, okay, had transplant rejection? Just remember this mnemonic graft. Okay, kidney transplant rejection occurs, okay, again, when the recipient's immune system recognizes, all right, the transplanted kidney as a foreign entity or foreign body. Okay, so it will create antibodies against it. However, all right, there are different signs and symptoms that you might be able to determine, okay, if it's already rejecting the donated kidney. Okay, so just remember this mnemonic graft, letter G, okay, stands for graft tenderness. What do you mean by graft tenderness? When we say graft tenderness, the patient would be able to complain of pain, okay, in the graft site. What else? Check if the blood pressure, the BUN, and the creatinine have increased. Rise in BP, BUN, and CREA. As well as, take note, kindly add, decrease in urine output. Letter A, rapid weight gain. I just put it there. Decrease urine output. Okay. So the weight of the patient, very important. You have to check, okay, if it gained rapidly. Fever, check for the temperature more than 37.8 degrees Celsius or 100 degrees Fahrenheit and above, as well as flank tenderness. It's the same thing with graft tenderness. So these are signs of transplant rejection. Okay. Also check if there would be swelling or edema due to decreased output and rapid weight gain. So these are the signs and symptoms that the client might experience if he or she had kidney transplant rejection. So is it important to report any of these signs and symptoms? Your graft. Is this important? Yes. All right. So can we review what is letter G? Signs of kidney transplant rejection, graft pain, very good, or tenderness. Letter R, rise in the blood pressure. What else? BUN and creatinine. Letter A, a rapid weight gain, decreased urine output. Letter F, check signs and symptoms of fever or flu-like signs and symptoms, not just fever. Include flu-like signs and symptoms. Letter T, fatigue, fever, flu-like signs and symptoms. Temperature is high, tenderness, or flank tenderness. Is this clear? Graft, signs of kidney rejection, yes. Now let's proceed with your disorder of your kidney. We have what we call your nephrotic syndrome. So familiarize yourselves with the signs and symptoms of your nephrotic syndrome. Here we have your hypoalbuminemia, hyperlipidemia, massive proteinuria, and what about this picture, the girl and the ankles? What do we have here? Yes, your pitting edema and your facial swelling. Why? Why did this happen to nephrotic syndrome? Okay. Keep in mind that nephrotic syndrome, okay, is characterized by, okay, a damage in the glomerulus. When you say glomerulus, what do you mean by glomerulus again? What does it do with our body? The glomerulus is used to filter, right, the blood from our body. However, okay, if we have nephrotic syndrome, this may be caused by autoimmune disease, all right, that will attack the glomerulus. So if the glomerulus is damaged and this is used as your filtration, expect that the glomerulus will be widened. Okay, the pores of the glomerulus will be widened. Now, what can happen if that pores that is used for filtration is bigger? What will happen? Ineffective filtration. Okay, so can we lose substances that is needed to be reabsorbed by the body? Yes, all right. Very important is our proteins. Okay, loss of plasma protein. Okay, so expect we can have what we call your hypoalbuminemia. All right, a decrease in albumin, which is a major protein in our blood. Okay, what will happen to the fluids? If we have a decrease in the albumin, which will decrease the oncotic pressure, what can happen to our fluids in the body? This may result in what? If we have low albumin level, all right, this may result to hypoalbuminemia or fluid retention. Edema or fluid retention. Now, also take note, can you see this like a glass? Okay, this is actually what you call your frothy urine, all right? So it's like a bubbly, frothy kind of urine. This is due to the presence of proteins. Since we are losing proteins, okay, proteins will be found, okay, as one of your assessment when you do urinalysis, okay, we can have proteinuria, meaning there will be presence of protein in the urine. And this is your hallmark sign. Take note, this is not less, this is massive. Massive or heavy proteinuria. This is your hallmark sign, okay, of nephrotic syndrome, meaning the kidneys leak large amounts of protein in our urine, okay, leading also to hypoalbuminemia, low levels of albumin in our blood. Albumin again is our oncotic pressure or pulling force of our liquid, but since this is decreased, okay, this may lead to edema or swelling, especially in the ankles or even around the eyes. So fluid retention. Now, as a compensation of our body, all right, since we have proteinuria, this may lead to the synthesis, okay, of our liver, which we call lipoprotein synthesis. Okay, in order to compensate for the losing proteins, okay, the liver will try to synthesize lipoproteins. Lipo meaning lipids, proteins meaning proteins, all right? So this may result to, aside from trying to compensate for the protein, this may also lead to hyperlipidemia. When we say hyperlipidemia, elevated levels of lipids. And what are lipids, guys? What are these? These are our fats, cholesterol, triglycerides in the blood, okay, which are common in nephrotic syndrome. So take note of these red fonts. Okay, these are signs and symptoms of your nephrotic syndrome. Again, due to the damaged glomerulus, the pores for filtration are widened, meaning it will become bigger, all right, or large. Therefore, if the pores are large, okay, we can now lose proteins, all right? And one of your plasma protein is your albumin, which is needed, okay, by the pulling force of your liquid. But since we have low albumin level, this may lead to fluid retention or edema, especially in the ankles or in the eyes. Now, what kind of what kind of urine are we going to check in nephrotic syndrome, guys? What kind of urine? Frothy urine. Okay, meaning there will be presence of proteins, massive proteins or heavy proteins. One of your hallmark sign of nephrotic syndrome. So leakage of proteins in the urine. As a compensation, the liver will try to synthesize lipoproteins because of the loss of proteins. However, the byproduct of lipoproteins, this may lead to hyperlipidemia, elevated levels of lipids such as our cholesterol and triglycerides. Guys, in order to manage our nephrotic syndrome, what would be our diet for the patient? High or low protein? What do you think? Okay. Take note that we are losing proteins, right? So, this is the only syndrome related to kidney, okay, disorder that is needing high protein. All right. If not, the rest would be low protein diet due to uremia or azotemia. Okay, but here the cause is damaged glomerulus. Since we are losing proteins, expect that the diet for the patient here is high protein diet. What kind of high protein diet? Lean protein, chicken, chicken breast, fish, all right, soya or beans. What about fats? High fat or low fat? It should be low fat because of zero fats or low fat because of hyperlipidemia. What about sodium intake? Why low sodium intake? Due to fluid retention. What about fluid intake? Decrease as well. Now, we can give also pharmacological interventions such as your atorvastatin. When you hear the word statins, what is this used for? Atorvastatin. These are medications for what? To manage the cholesterol level or our lipids, anti-lipidemic medications. What about your captopril? What is this? Your prils. ACE inhibitors, for what purpose? Are we expecting high blood pressure here? Guys, due to what? Due to fluid retention. Very good. What about diuretics? Diuretics due for fluid retention as well. Corticosteroids, this is used for what? Inflamed glomerulus because of anti-inflammatory drugs used to manage, all right, our inflamed glomerulus due to autoimmune, all right? Albumin IV. If indicated by the doctor, this is used for what? To increase the level of albumin. To increase the level of our albumins, okay? To increase our oncotic pressure to prevent what? To prevent edema. Is this part clear? Nephrotic. Take note of the diet, high protein diet here. Okay? Okay, so this again is your nephrotic syndrome. Okay, your hypoalbuminemia, hyperlipidemia, massive proteinuria. This is your common signs and symptoms for nephrotic syndrome. So for you to remember nephrotic syndrome, just remember nephrotin. Okay, right in there, nephrotin, because we have presence of protein in the urine. Nephrotin. So that is your nephrotic syndrome. This one of the only, all right, if not the only syndrome that is needing high protein diet when it comes to kidney disorder due to damaged glomerulus. So take note of the medications here. Now, so in comparison to your nephrotic, okay, we also have what we call nephritic. Okay, nephritic syndrome, okay, which is also termed as glomerulonephritis. So this is another kidney disorders, okay, that is included, okay, or including infection. Okay, when you say itis, inflammation, but this is due to infection, okay, of what? Of your group A beta hemolytic streptococcus. All right? Staphylo or streptococcus. Are these bacterial infection? Yes. Okay. Usually happens where? Start of your glomerulonephritis before your kidneys. This usually happens where? Start of signs and symptoms usually happens in your sore throat. Okay, upper respiratory tract infection, okay, that may last 2 to 3 weeks, all right? So as a compensation of your body, okay, immune complex deposition, nephritic syndrome is triggered by your immune complexes, all right, that will be trapped in your glomeruli or your glomerulus. So immune system clusters of your antibodies and antigens, okay, will be trapped in the glomerulus. Now, if it's trapped in the glomerulus, can that trigger inflammation? Yes, inflammatory response would be activated, okay, in the glomeruli itself, all right, affecting its permeability. Now, for nephritic syndrome, I want you to remember that the urine here is different from your nephrotic syndrome. Since there's an inflammation due to infection, okay, this can cause scarring or thickening of the blood vessels, all right, within your kidneys, which can lead to bleeding, all right, that may be manifested by cola-colored urine. Take note of this one. The urine in your nephritic syndrome is cola-colored urine, all right, due to bleeding or injury in the blood vessels of your kidneys. Now, scarring or thickening would then also slow down the glomerular filtration rate. So what will happen to the level of your BUN, creatinine, potassium, and sodium, high or low? All will be increased. All right, so expect there will be increase in the waste product, increase in your potassium, hyperkalemia, increase in your sodium, hypernatremia. So would hypernatremia, all right, and slowing of your glomerular filtration rate leads to fluid retention, yes or no? Yes. So what will happen to the blood pressure? It will become high. What will happen to the urine output? Decrease urine output because we are retaining fluid. Therefore, if we have a decreased urine output, would that make our urine concentrated or diluted? If the urine output is less, okay, do we have More water in the urine or less water in the urine? Guys, less water. So if the water or the solvent is less, is that concentrated or diluted? It will be concentrated, leading to increased urine-specific gravity. Did you get this part? Yes. Okay. So again, sige, let's repeat. Ulit daw, ulit. Alright. What is the main cause of your nephritic syndrome or acute glomerulonephritis? Main cause. Everybody should answer. Main cause? Group A, beta hemolytic strepto or staphylococcus infection. Is that a bacterial infection? Yes. Leading to what initial symptom? Sore throat, right? So sore throat symptoms roughly for how many weeks? 2 to 3 weeks. Now, as a compensation of your body, antibody response, those antigens, okay, or those bacterial infection in the throat can go down to your, or can be trapped in the, where will it be trapped? Where will it stay? In the glomerulus. Is glomerulus needed for filtration? Yes. Okay. Now, what will happen if it's trapped in the glomerulus? Can that infection trigger inflammation? Yes, leading to what we call glomerulonephritis. Itis is inflammation. Glomerulo, okay, it's in the glomerulus of your nephrons. Glomerulonephritis from the word itself, all right? Now, since there is inflammation happening, could that lead to scarring or thickening of the epithelial cells of your glomerulus? Yes, okay. Will that injure the blood vessels? Yes, leading to what kind of urine output? Cola-colored urine. It's like the urine, Coke-colored urine. Cola-colored or Coke-colored urine. Now, since the blood vessels of your glomerulus are scarred or thickened, okay, will that slow down or will that increase the rate of your GFR? It will decrease. So you won't be able to properly filtrate, okay, your substances and your fluids inside the glomerulus because it is inflamed, right? So if the glomerular filtration rate is slowed down, would it be possible that the electrolytes, the waste products will be retained? Excess electrolytes and waste products will be retained in the body. All of this, high or low? All of this will be high. Expect that one. Okay. Now, what will happen also, all right, will be retention of your fluid, right? Because you are slowing down the filtration. Therefore, excess fluid will be retained as well, leading to what kind of blood pressure? So we have hypertension. Now, if we are retaining fluid, take note of this one. Listen, if we are retaining fluid, okay, will that increase or decrease our urine output? We are reabsorbing the fluid. We are retaining the fluid. So, therefore, urine output is decreased. Okay, do we have more or less wee-wee urine? Less, all right? So what will happen, okay, if there will be less urine, meaning there will be less water as well in the urine, right? So less water, Okay, in the urine, meaning there will be less solvent in the urine. So more solutes, less solvent. That makes our urine concentrated or diluted. So the urine is concentrated, leading to high or low urine specific gravity. So if it's concentrated, USG is always high. Did you get this part? Okay, good job. Very good. I'm proud of you. All right. So, any more questions? Glomerulonephritis. None. Okay. Guys, did you get the difference between nephrotic versus nephritic? Because usually they compare it. Did you get the difference? One is due to infection, the other one is due to inflammation of your glomerulus, autoimmune. Now, I want you to remember that nephritis is also associated. I'm not sure if you've heard this word, but one of the kidney abnormalities, we call this one your Alport syndrome. Okay. This syndrome is related to your nephritic syndrome or glomerulonephritis. So this is one of your disease that damage the tiny blood vessels of your kidneys. Okay, and attacking your glomeruli. So again, this is associated with glomerulonephritis syndromes. Okay, symptoms plus deafness and visual abnormality. So you just add this kind of symptom. For your Alport syndrome, okay, the cause for this one is not infection but hereditary. However, same signs and symptoms with your nephritic syndrome plus deafness and visual abnormalities. So just an additional disease related to this one. So for you to remember, okay, nephritis syndrome, just remember this mnemonic. Also, the acronym is nephritis. All right, acronym is nephritis, which represents a set of clinical signs and symptoms associated with this disorder. No urine or oliguria, reduced urine output, okay, which can be a sign of your kidney dysfunction. Edema, swelling, of course, are expected due to fluid retention. So this can be seen in the hands, in the feet, or in the face. Pallor or paleness of the skin, okay, which may be associated with anemia. Hypervolemia, increased blood volume due to fluid retention. Reddish brown urine, okay, this is your cola-colored urine with the presence of blood or hematuria. Increased BUN and creatinine, elevated blood levels of BUN and creatinine are one of your markers for this kidney dysfunction. Tenderness in the flank area, pain or tenderness on the backside, okay, or which can indicate kidney discomfort, okay. Increased specific gravity, so meaning your urine is concentrated, all right, plus, all right, the initial symptom, which is your sore throat. So all of this, do not forget, all of this would be, okay, concerning your acute glomerulonephritis or nephritic syndrome. Is this part clear? Yes. Can you give me a minute? I'll just go to the restroom. Is this okay? Just 1 minute. Sorry. Okay, wait. Okay, sorry about that. All right. Do you have any questions with nephritis? Is this part clear? Okay. So that is your nephrotic versus your nephritic. Okay. So before we proceed with kidney stones, sige, tell me if it's nephrotic or nephritic. High protein diet. Okay. Massive proteinuria. Cola-colored urine. Sore throat. Frothy urine. Cause is group A beta hemolytic strepto. Edema. Edema. Both. It should be both. Both have fluid retention. Take note of that one. Both have fluid retention. Hyperlipidemia. Hyperlipidemia. Okay. Fluid retention. Fluid retention. Both. Good job. Decrease your sodium intake. Decrease sodium intake. Both. Both. Okay, take note. Both. Low albumin levels. Nephrotics. Alport syndrome. Swelling. Face, hands. Both as well. All right. So that is your nephrotic and nephritic. In some symptoms, we have this. We have similarities. In some causes, we have differences, as well as the signs and symptoms. All right. But the cause is entirely different. One is due to infection. The other one is inflammation. Let's now talk about your renal calculi. I believe this is familiar to you, all right? Our kidney stones. Do you know someone who had kidney stones, or did you have kidney stones before? So we have the following types of kidney stones. We have your calcium oxalate. We have your uric acid stones. We have your struvite stones and your cystine stones. When you say calculi, we are referring to the stones in your kidneys. All right? So, calcium oxalate stones, these are stones that is one of the most common kidney stone. All right? So, to reduce the risk of forming calcium oxalate stones, we have dietary modifications such as our acid ash diet. All right. We have your cranberries, corn, cheese, plums, and prunes. All right. So these type of stones are caused by alkaline foods such as your spinach, rhubarb, rice bran, almonds, wheat, berries, corn grits, cocoa powder. That's why we give your acid ash diet. Cranberry juice is usually suggested because this can help acidify the urine. So in your calcium oxalate stone, from the word itself, calcium, so it's alkalotic or alkalinic. Okay, we need to acidify our urine by giving our cranberries. Corn is another food that can contribute to acidifying the urine. Some types of cheese are also considered as acceptable acid ash diet, as well as plums and prunes. So these also have acidifying properties. For your uric acid stones, okay, uric acid stone is another common type of kidney stones. Now, this time, the cause for uric acid, since your urine is acidic, okay, the cause would be your all boys. All boys, meaning these are food that are rich in purine, okay, high purine diet cause. What are all boys? So these are already indicated there. A, anchovies. What are anchovies? What's the Tagalog for anchovies? These are your dealies, okay? These are dealies or small fish, your anchovies. What about lentils and legumes? Your lentils and legumes, these are your munggo, right? If you've heard about that one. Beers, organ meats, your liver, yeast, sardines, and salmons. Okay, so all boys, this is your mnemonic for high purine diet, all boys. Anchovies, lentils, legumes, beer, organ meats, yeast, sardines, and salmon. Now, as a management, okay, that this kind of diet, alkaline ash diet, encourage the consumption of foods that would create an alkaline environment for the urine. Examples would be milk, green leafy veggies, except foods such as your cranberry, corn, cheese, plums, and prunes. Milk is one of your dairy product, of course, that are alkaline forming and can help increase the pH of urine. Green leafy veggies like spinach, kale, broccoli are also alkaline forming. So all other fruits except cranberries, okay, which is acidic. So this is your important note, okay, for alkaline ash diet that would be recommended for this type of stones, your uric acid stone, to reduce the risk of uric acid stone formation. Of course, do not forget, any type of stones, we need to stay well hydrated. All right? Plus, reduce also the intake of your all boys. Take note of this one for uric acid stones. When you say struvite stones, all right, this is also known as infection stones, often associated with urinary tract infection or your UTI caused by certain bacteria. So this bacteria produce urease, which can lead to formation of what you call your struvites. So as a management for this one, just remember low protein and low sodium diet. When you say cysteine, it's the same, all right? But this is just a rare type. This is associated with high protein diet. So same management with Strovite, low protein and low sodium diet. Now, very important, guys, all of these type of stones, aside from the recommended diet management, all of this should be suggested to increase or hydrate the patient. The patient should be well hydrated here. Is this clear? This is how it looks like. Yeah, this is what we call your nephrolithiasis. Your nephrolithiasis. So, when you say lithiasis, okay, this is presence of stones. If it's nephro, the stones is located in the kidney or the renal pelvis itself. When you say ureterolithiasis, the stones is located in the ureters. But same symptoms, same pathophysiology, okay? Both stones can cause obstruction in the urinary passageway, therefore, okay, leading to acute pain. Kidney stones is very painful, all right? It's like it's a pain, it's like a knife stabbing your back. So it's very excruciating, all right? Excruciating pain at the flank area, at the back, or even below the ribs that radiates to the lower abdomen or groin. So pain plus radiating pain. And even upon urination, you can also feel the pain due to injury to the blood vessels. So that obstruction, that stone can injure the blood vessels, and expect, okay, that whether it's nephro or ureterolithiasis, there will be presence of hematuria. When we say hematuria, okay, you can see what? Hematuria. You can see blood in the urine. Okay, one of the sign as well. Presenting signs and symptoms. Hematuria or presence of blood in the urine. Would there be also chances of frequent urination and urgency? Aside from pain and hematuria. Yes. Okay. For severe pain, in some cases, client may experience nausea and vomiting. Now, drug of choice, the treatment for treating these stones would be, of course, your analgesic or your meperidine, okay, or your Demerol. We need to watch out for complications such as oliguria, UTI, or hydronephrosis. When you say hydronephrosis, this is fluid stasis above the site of obstruction. Now, can you tell me what is, aside from pain reliever, all right, what is the best treatment for kidney stones? If not hydration, if not diet modification, what is the best treatment for this one? If not managed by hydration and diet. We have what we call your ESWL. All right, take note of this one. ESWL stands for extracorporeal shockwave lithotripsy. When you say extra, it means it's outside. Corporeal, body. Corp, right? Your body. So it's outside your body. Therefore, this is non-invasive. With the use of shockwave, okay, tripsy, meaning when you say tripsy, it means breaking down. Lith, it means the stones, the kidney stones itself. So from the word, okay, you know the meaning. Extracorporeal, outside the body, breaking down the stones, lithotripsy, with the use of your shock wave. So this shock wave is used to break stones in fragments, making it easier for them to pass naturally through the urinary tract. All right? So ESWL position, supine position, or lying on the back. And then pre-procedure, NPO, usually 6 to 8 hours. The patient is asked to fasting to reduce risk for aspiration during sedation. So IV sedation is administered to keep the patient comfortable and relaxed. Post-procedure, some bruising may occur, all right, after the shock wave. Bruising is expected, okay, around the area where the shock waves were directed during your ESWL. So this is not reportable, but this should be discussed to the patient prior, all right, that bruising are expected after ESWL. Complications such as your obstruction, temporary obstruction, hydronephrosis, temporary swelling of your kidney, UTI, and pain. Okay? These are complications that might happen to your patient. Again, hydronephrosis, fluid stasis above the site of obstruction. Your treatment here would be what you call your nephrostomy tube. All right, nephrostomy tube. So the kidney will swell due to fluid stasis above the site of obstruction. That is your hydronephrosis. What is nephrostomy tube? This is how it looks like. So this is your ESWL first. So it's like a shock wave breaking down your stones. So this is expensive. And your nephrostomy tube is used if it's still blocking, okay, your urinary tract, or if there's still needed to drain, okay, urine from the kidney. So post-surgery drainage as well for your nephrostomy tube. This is just temporary. Now, if you have kidney stones, expect that you might have also complication like UTI. Okay, so these are partner. You can have UTI and then stones, or you can have stones or UTI. And UTI, of course, are familiar to us. And this is more common for healthcare professionals such as nurses, all right? And those that have poor hygiene. So, location of your UTI, if it's pyelonephritis, it's found or located in the kidney. The infection started in the kidney. If it's cystitis, the location or the infection is in the bladder. All right? So, poor hygiene, sexual intercourse that are using what do you call that, sexual toys that are not sterile, for females after swimming when you don't change your underwears right away, and then improper vaginal and male hygiene. All right, so management for this one. What's your management for UTI? What's our management? Okay, very important is we need to increase our oral fluid intake. We need to avoid bladder irritants. What are the example of bladder irritants? Guys, examples of bladder irritants. Coffee, smoking, alcohol, all right? Those are bladder irritants. Now, what happens in your UTI? So, take note, this is ascending infection. This is going up. So, it will start from the outside, okay, of your body, going up to your kidneys. So, take note that this is also very painful, and this may cause you to have fever or increase in the white blood cells. Flank area pain, burning sensation, you wanna pee right away, and you pee all the time. Urgency and frequency. Plus the presence of hematuria, blood in the urine. Okay? So again, management, increase hydration, acid ash diet, cranberry juice, or supplements may help some individuals with UTI. Warm sitz bath is okay. Wiping from front to back, not back to front, okay? Front to back after using the toilet. Urinating before and after sexual activity may also help reduce UTI. Drug of choice for this one, all right? Drug of choice would be your anti-infectives. We have the following. And we also have your urinary analgesic, okay, which is what we call your pyridium. Your pyridium is a medication that will help relieve pain and discomfort associated with UTI. Some people can do warm sitz bath. This can also alleviate discomfort. But hot baths should be avoided. Okay, just warm sitz bath. So this is for your UTI. Is this part clear? Yes. Okay, now UTI is more common to males or females? More common to females. Now, for your BPH, of course, this is only for male kind of syndrome. So BPH stands for benign prostatic hyperplasia, in which your prostate here is enlarged. If it's enlarged, would that be able to cause obstruction in the urethra? Yes, okay. So obstruction in the urethra causing dribbling urination. So it's like that in the picture. The male is dribbling urination. It's like that. Due to weak urine stream, and that the male would try to strain, okay, while voiding, causing blood or presence of blood in the urine, hematuria. So it's like the same thing with your UTI, but this is more for males due to enlargement of the prostate or your BPH. Now, there's one NCLEX question that my previous student told me. He was asked regarding BPH. Okay. Just remember this drug. Okay. It was asked to him. Sopalmeto. This is an herbal medication that would help alleviate the symptoms of your BPH. So when you hear the word Sopalmeto, just remember BPH. Okay, this is your herbal meds for BPH. Finasteride, okay, is also medication that will relieve the urinary symptoms, as well as your terazosin. Okay, terazosins are your alpha blockers, which will also relieve the symptoms quickly. So we need to watch out for hypotension because this is an antihypertensive drug. For pain, same thing, we still use pyridium. All right, for urinary analgesic. Now, for management, these are the drugs. But for treatment, okay, we have what we call your TERP. Okay, are you familiar with this, your TERP? What is TERP? This is your transurethral resection of the prostate. Okay, so this is how it looks like. All right, this is your TERP. And the man sitting down here, this is your CBI, continuous bladder irrigation. So after TERP, do we do CBI? Yes, okay. So position for TERP is, of course, lithotomy, right? Pre-procedure, NPO, 6 to 8 hours. General anesthesia is used, of course, because when you remove the tissue, it's really painful. So general anesthesia is recommended for the client. Post-procedure, of course, continuous bladder irrigation is needed for what purpose? Guys, CBI is needed for what purpose? After TERP, what do you think? Okay, to prevent, okay, clot formation or stasis of the blood. All right. Now, would you be able to report right after CBI if you see pink tinge urine? Is that reportable? Yes or no? No, it's expected or normal. Okay, because you are irrigating the bladder right after your TERP, and there's still presence of blood, so expect that will be reddish pink or pink tinge urine, and then you'll wait for a few hours or even few days for it to become normal color or yellow. What you need to remember or to report if there are any signs of infection after perforation, all right, and even clot formation, all right? So report bladder spasm, all right, for your both for your TERP and for your CBI after your CBI. Is this part clear? Yes. Okay. So let's now move on with your burns. This is our last topic. Okay. Burns may be caused by different causes, we have your thermal burns, chemical, electrical burns, or even radiation burns. Okay? But here, we need to know the stages. Okay? We have different stages or types of burns. We have first degree burn and second degree burn under your partial thickness. We also have your stage 3 and stage 4. This is already full thickness burns. When you say first degree, this only affects, the top layer of your skin, which is your epidermis. Appearance for that one would be just like sunburn. Okay, so this is the first picture. This is your first degree burn. Second picture, that's your stage 2. Okay, that affects the dermis. Okay, underlying layer of your skin, which is your dermis. So epidermis plus dermis. Now, what happens? This can cause blistering, severe pain, redness, swelling, and moist formation. This is one of the most painful type of burns. But this is still under partial thickness. Full thickness stage, we have your stage 3. Okay, that affects already your subcutaneous, your fats. So they may often appear as white, charred, or even leathery, pearly white appearance. Stage 4, just remember this is the last stage. So it affects your epidermis plus your dermis plus subcutaneous, including your muscles and bones. And the color for this one would be black charred. So you can also see the bones already. So this is your first stage, second stage, third stage, fourth stage of your burns. So we have two kinds of phase, all right? We have the emergent phase versus your diuretic phase. When you say emergent phase of a burn injury, all right, this usually happens when there's fluid shifting, okay? Fluid shift from the bloodstream into your interstitial spaces, okay? Leading to, all right, natremia, all right? And of course, hyperkalemia. The blood vessel, all right, would lead to loss of fluids, all right? So hypovolemia. So your blood will be concentrated and there will be no urine output due to hypovolemia. So reduced urine output. Your priority here would be fluid volume deficit. Now, as the patient tries to recover, okay, we also have what we call your diuretic phase. Okay, this time the fluids will be remobilized. Okay, the body begins to mobilize and excrete excess fluids. All right. So the difference here, all right, would be able to increase, all right, decrease the your potassium and increase your blood volume. So there will be hypervolemia. So if you have too much water, okay, expect that the blood would be less concentrated. So there will be decreased hematocrit and urine output will become normal or increase in urine output. And this time, of course, we have to watch out for infection after the burns. That is why, as a management, all right, nurses, very important, okay, number one, pain management. We can give your NSAIDs, your Tylenol, all right, or other pain management. We can also do your debridement. When you say debridement, okay, this is the process of removing dead or damaged tissues to prevent infection. Culture and sensitivity test, okay. If there are any chances of bacteria that are present, so we might help guide them, giving them antibiotic treatment. Example would be your sulfadiazine. All right, this is your antibiotic treatment. For example, for infection, if you have burns. Now, I want you to, I think you have this one, the rule of nines. Do you have this? I sent it to you, the handout. Okay, let's just try to discuss, all right, one by one. So anterior part of your head is 4.5, posterior is 4.5. Okay, but the whole head, how many percent? 9. Okay. Anterior torso, half would be 9. Posterior torso, half would be 9. Okay. Lower abdomen is 9. Back is another 9. Okay. Left arm, anterior 4.5. Left arm posterior 4.5. Right arm anterior 4.5. Right arm posterior 4.5. Now, if there's no indication anterior or posterior, expect, for example, just left arm. How many percent if it's left arm only? It's 9%. Very good. What about your perineum? It's 1%. Okay. Legs would be times 2 of your arm. Anterior 9, posterior 9, left and right. Okay. But the whole left arm, left knee, left limb, it's 18. Whole right limb, it's 18. Is this clear? Rule of 9? Yes. Okay. Let's try to identify. Entire face and back of the head, how many? 9. Genitalia? 1. Circumferential burns of the right arm? Right arm. 9. Very good. Upper half of the anterior torso? 9. Circumferential burns of the lower half of both arms? Both arms. Still 9. Okay. Anterior half of the head? 4.5. Upper half of posterior torso? This one. That is your 9. Okay. Now, would you be needing to compute for the total of this percentage? Would you total this one? We call that one your total body surface area. Now, this is your last computation. I want you to take note of this formula. Okay. When it comes to burn, is it possible that the client may be dehydrated? Yes. Okay. So for computation of fluid replacement, okay, take note of this one. Okay. Computation of fluid replacement. 24 hours TBSA times weight. So TBSA times weight in kilograms times 4 ml. 4 ml is your standard. Okay. So can you compute for the total fluid requirement for 24 hours? TBSA given is 45%, 50 kilograms. Weight of the client, how many is this one? So this is 45 times 50 kilograms times 4 ml. How much is your total fluid requirement for 24 hours, guys? How much is the total? Okay, it is 45 times 50 times 4, it's 9,000. However, okay, if it's just being asked to you first 8 hours How many? Half of 9,000. So how many is it? 4,500. What if it's asked to you second 16 hours? It's still half of the total. So it's still 4,500. It's the same thing. First 8 hours, second 16 hours. All right? It's half of your total for 24 hours. Is this part clear? Yes. Okay, so let's try to compute for this one. Age is 35 years old. Face, neck, front and back, upper thorax, chest, right arm. Determine the TBSA of the patient. How many is this one? What's your answer? Face, neck, front, and back. How many percent? Guys. 9. Upper thorax, chest. Just the chest. One by one first. Upper thorax, chest. How many percent? It's also 9. What about right arm? There's no indication if it's anterior or posterior. It's still 9. So 9 times 3. So this is your 27. Okay. Compute for the total fluid requirement. If your TBSA is 27%, weight of the client is 45 kilograms. 45 kg. This client is 45 kilograms. TBSA is 27%. How many total fluid requirement for 24 hours? 4,860. How about for the second 16 hours? How much is needed? 2,430. Did you get this part? Rule of 9 plus fluid resuscitation, your Baxter formula? Okay, good job. All right. So familiarize yourself with this one. This is your formula for computing for TBSA. Just total this one. Now, what if the weight is given in pounds? What do you need to do? Divide it by 2.2. Very good. Good job. Okay. And that is the end of our GUT plus burns. Now, are you ready to take your post-test? Yes. Okay. So, giving you 25 minutes. It's just 20 items. Twenty to 25 minutes. Please let me know if you're done. Are we all done? How about the others? Not yet. Okay, 5 minutes. All right. So how about the others? Are we finished? Guys, are you done? Okay, so let's start to review our answers. Question number 1, nursing management prior, all right, to IVP would include which of the following? 1, fat-free meal the evening prior. 2, placement of a retention urinary catheter to facilitate dilation of the bladder sphincter. 3, do we need cleansing enemas prior to provide visualization? Or explaining the importance of following direction regarding voiding during the test. What's your answer? IVP is intravenous, okay, injection of your contrast dye for better visualization of your kidneys, ureter, and bladder. Now, do we need a clear visualization of our GUT parts? Can we do number 3, cleansing enemas? Yes, okay. Number 2, the nurse is educating a group of nursing students about the goal of your RAAS. What are your answers? Which of the following statement is correct, Sata? 1, it is a regulator of blood pressure and cardio function. Yes or no? 2, is it related to maintaining normal glucose level? No, it's not. 3, can it promote sodium reabsorption? Yes, by stimulating what hormone? What hormone did we stimulate? What hormone is that? Sodium and water reabsorption. Our aldosterone. Very good. Does it maintain fluid balance? What about vasoconstriction? So all except number 2. So our goals of your RAAS is to increase your blood volume as well as increase your blood pressure. 3, which of the following will alert? Okay, the question is alert the nurse prior to IVP. 1, client ate breakfast, yes or no? The client should be on what? NPO. Client took laxative. Is it okay? Client reports to have experienced claustrophobia in the past. No, not included. Weak femoral pulse. This is more for renal angiogram. Client reports allergy to iodine. Would you include this one? Yes, all right. So because of the contrast medium involved. So 2, 3, and 4 is either not related or would not alert the nurse. 4, primary teaching for a client following ESWL procedure is what? Drinking of 3,000 to 4,000 cc of fluid, limit your fluid intake, increase intake of citrus fruits, or restrict milk and dairy product. What is ESW used for? First, this is for what disorder? In order to break down your stones into fragments. Now, would you be needing to limit or hydrate the client? Limit fluid intake or hydrate? Hydrate your client. Okay, so your answer is number 1, to facilitate excretion of your renal stones. 5, a nurse is obtaining health history of a 5-year-old who had admitted with acute glomerulonephritis. Which information would the nurse expect the client's mother to report? So glomerulonephritis is associated to what disorder or symptom? Sore throat, measles, UTI, or child's immunization were administered at the start of the school. So it's number 1. That is your initial symptom for your nephritic syndrome or glomerulonephritis. Number 6, you're providing education for a group of nursing students about nephrotic syndrome, SATA. Which signs and symptoms verbalized by the patient would require you to re-educate the student? So are we looking for positive or negative statement here? So which between these options are not included with nephrotic syndrome? Negative statement for nephrotic syndrome. This is SATA, but what? The only answer is 1. All right. Take note, SATA can be a minimum of 1 and maximum of all. So 2, 3, 4, and 5, wag nyo pilitin. These are all positive statement for nephrotic syndrome. 7, CKD patients have low EPO level. The patient is at risk for what? Low EPO. Very good. Anemia. All right. That will stimulate what blood cells again? Blood cells. Our red blood cells. 8, stage 5 CKD experiencing extreme pruritus has several areas of crystallized white deposits on the skin. What is this due to? Excessive amounts of what? We call this one your uremic frost due to the presence of your urea. Good job. 9. Your patient with chronic kidney disease is scheduled for dialysis. While examining, EKG is stated tall peak T wave. So the client has chronic kidney disease. Expect that what kind of imbalance can the patient have? All right, if it's tall peak T wave, that is indicative of what? Hypo or hyperkalemia? Hyperkalemia. Is hyperkalemia common to CKD patients? Yes, so that is your answer. 10. Patient with stage 4 chronic kidney disease ask what type of diet should they follow? It should be what? High or low protein? Sodium? Potassium? How about phosphate? Okay, everything should be low because all are elevated for your end-stage renal disease. Good job. 11. A client with bovine graft inserted to the left arm for hemodialysis during the immediate post-op period. Which of the following, if performed by the nurse, is best? Where is the graft site? Where is the graft site? Left. So where should you do your procedures? On the other side. Okay, so take blood pressure on the right arm. 12. Child with chronic kidney disease is undergoing peritoneal dialysis. For which associated complication would the nurse monitor? Okay, what's your answer? Number 3, why is this an answer? This can mean what? This can mean cloudy dialysate can be what? Signs and symptoms of what? Peritonitis. Okay, peritonitis. Infection, this signs and symptoms for that would be fever, flu-like signs and symptoms, redness on the dialysate part or in the peritoneal part. But peritonitis, it's cloudy dialysate. Did you get the difference? Okay. 13. Manifestations indicates acute rejection of transplanted kidney SATA. Hypertension, yes or no? Yes. Fever and chills. What's your mnemonic for acute rejection? Graft. Okay. What about number 3? Pain at the graft site. Yes. Overnight weight gain. Yes. Decrease urine output. Okay. Did you select all? Yes. Very good. 14. Physician writes the following orders for a client with chronic renal failure. Which order should the nurse question? Epogen, would you question? Yes or no? This is needed. Obtain daily weight. Weigh the client every day. No, it's very important. High protein diet. Why? What will happen? If you answer number 3, what can happen? Why would you question this one? This can lead to what? Manifestation. Presence of nitrogenous waste. Okay, which is your azotemia. Limit salt, is this okay? Yes, because the client might have hypernatremia. 15. For a male client in the oliguric phase of acute renal failure, which nursing intervention is most important? Oliguric phase. When you say oliguric phase, can the client urinate normally? Would there be presence of fluid retention or fluid loss? Fluid retention. So do we answer number 3? Yes. 16, female client with acute renal failures undergoing dialysis for the first time. The nurse in charge monitors the client closely for dialysis equilibrium syndrome, a complication that is most common during the first few dialysis sessions. Typically, dialysis equilibrium syndrome leads to what? What will you check for the patient if the client experiencing your DDS? Any alterations in the level of consciousness. So answer is number 1. Did you get this part? See? Very good. In managing dialysis disequilibrium syndrome, which of the following is the priority nursing action? If there's any alterations in the level of consciousness, nurses should slow down the rate of the dialysis. Would you report to the doctor? Yes, very important. 18. 35-year-old male client has full thickness burns to the anterior and posterior head and neck, front of left leg, and perineum. What's your answer? Anterior, posterior head and neck, how many? 9. Front of left leg, how many? 9. Okay, perineum. 1. So how many are the total? It's 19%. 9 plus 1, 19. 19. What is the total fluid requirement for 24 hours of a client who had severe burns? 70% of the total body surface area weighing 55 kilograms. What's your answer? How do we compute for this one? 70% times what? 55 kilograms times 4. That's 15,400. Did you get this part? Yes. What about number 20? Compute for the total fluid requirement for 8 hours, okay, of a client who had severe burns, 50% of the total body surface area weighing 50 kilograms. Okay, so how many? What's the total fluid requirement for 24 hours for this client? 24 hours. So it's 10,000. So the answer is, if it's 8 hours, you just divide it by 2. So the answer here is 5,000. Did you get this part, everyone? I'm so proud of you, okay? So if you just listened a while ago to our lectures, you would be able to answer effectively for our JUUT. All right? So that's the end of our lecture. Common, no? Not necessarily, Ma'am and Len. Okay? So either there is comma or no comma, but the answer is correct. Okay? So thank you very much and have a great day. Please review for GUT and answer more practice questions. Thank you.
Thank you so much po, ma'am. And nurses, tomorrow our class is immunology by Sir Palabrica. So please don't forget na mag-evaluate po tayo ng lecturer. And yung my score po natin sa post-test, please indicate your tracking card. So see you tomorrow, nurses, and thank you. God bless po. Thank you, nurses. Thank you po.